Welcome back to Oncology for the Inquisitive Mind. What was going to be our quick sprint through ESMO, but as it turns out, we are incapable of doing anything quickly or concisely. Joining me in this rambling affair is none other than Josh Hurwitz, who is very busy and can't say no to anything. Josh, how are you doing?
I'm doing well, mostly because you're in a singlet and you're turned off your camera now. And he's showing that he's been working out in the sunny Queensland weather, so it's quite nice to look at.
What can I say? I have the ability to do that.
What are we doing today?
We are on our third episode of our marathon, not a sprint, of ESMO recaps. And today we're going to talk about 3 tumour streams. I almost said 3 trials, but there's so many more than that. 3 tumour streams: lung cancer, neuroendocrine tumours, and melanoma, that have a number of similarities and so are often grouped together. So, Josh, why don't you kick us off with our first lung cancer nominee for the coveted award of our favourite, the Oncology for the Inquisitive Mind favourite trial in lung cancer.
Yeah, Michael, thank you so much. I'm looking really forward to doing this. So we actually spoke about this a couple of episodes ago before ESMO came about, but it's the Delphi 303 study, which is tarlatamab with first-line chemoimmunotherapy for extensive stage small cell lung cancer. And it's always going to get a mention because small cell lung cancer is terrible. For those that haven't listened to that episode, of which you definitely should, tarlatamab is a delta-like ligand 3, DLL3, thus the name, directed bispecific T-cell engager immunotherapy, which has been seen to improve survival in those previously treated with small cell. This is evaluating the safety and activity of tarlatamab in combination with atezolizumab or durvalumab, because they're both now used in extensive stage small cell lung cancer as first-line maintenance therapy in this cohort of patients. So it's a phase 1b trial, so there's no head-to-head in this, but you have to be over 18, good ECOG status without disease progression after the classic platinum and etoposide chemotherapy, and you're then given tarlatamab IV every 2 weeks, with atezolizumab every 4 weeks, or durvalumab every 4 weeks as maintenance until progression. Patients were enrolled across 30 centres, and I guess you probably have to, given that people don't do too well and recruitment for these trials can be difficult. The primary objective was to look at whether you could do a phase 2 dose or a maximum tolerated dose. And so all patients who received at least 1 dose of tarlatamab were included, and the finding of these results were as follows. The median time from start of standard of care chemoimmunotherapy to start of tarlatamab was about 3.6 months, which is fine. Median follow-up was about 18.4 months. And the most common AE or adverse event was hyponatremia, about 10%, anemia with 8%, and neutropenia with 7%. Serious adverse events occurred in about half of these patients, with the most common being cytokine release syndrome of about a quarter of patients. That's actually relatively manageable with steroids and other sort of immunomodulatory agents. There's also pyrexia and pneumonia as well. There are no deaths related due to this, which is good. So what it says is that it's manageable from a safety profile toxicity, and given that, it supports an ongoing phase 3 study. So that's actually quite interesting. And the one thing I did not mention, Michael, which is the final note here, is that median overall survival was about 25.3 months. Pretty good.
Which is excellent for small cell.
It's like doubling. It's doubling that of the classic Empower trials.
Yeah, I think it was Pacific with Durva as well. So a very good trial. Tarlatamab probably pushing its way up into the first line, which I think everyone who treats lung cancer saw coming.
So sassy.
I mean, it is true, because it is probably the best drug that we have had in small cell lung cancer since
chemotherapy?
Since platinum-based chemotherapy, exactly. So I think everyone is saying, right, we've got it in second line. When can we use it in first line? Our next study is a tyrosine kinase inhibitor against HER2. And this is cevabertinib, and I definitely didn't practice pronouncing that, in advanced HER2 mutant non-small cell lung cancer. This is the SOHO-01 study, a phase 1/2 study with multiple cohorts. Now, a little bit of background. HER2 positivity, specifically gene mutations, which is distinct from the HER2 positivity in breast cancer where it's HER2 overexpression, are present in about 4% of all non-small cell lung cancers, but it is something that is increasingly recognized as an important target. Cevabertinib is a potent reversible oral HER2 tyrosine kinase inhibitor is targeted at patients with pre-treated or treatment-naive advanced HER2 mutant non-small cell lung cancer. In this study, patients with HER2 mutant non-small cell lung cancer were treated with cevabertinib at various different doses, 20 milligrams BD in 3 different cohorts, and each of these cohorts had different patient population. Cohort D had patients who had had previous systemic therapy but were naive to HER2 targeted therapy. Cohort E were patients that had had previous HER2 target antibody drug conjugates, looking at UTDXD. And cohort F were those naive to systemic anti-cancer therapy for advanced disease altogether. The primary endpoint of SOHO 01 was objective response rate by blinded independent central review, and secondary endpoints were the duration of response and progression-free survival. As of data cutoff, they'd managed to find 209 patients with HER2 mutant non-small cell lung cancer, 81 in cohort D, 55 in cohort E, and 73 in cohort F. Overall response rate across the 3 cohorts was 64% in cohort D, that's previous systemic therapy but no anti-HER2 therapy, 38% in cohort E, which is unsurprising because it's patients who have had previous anti-HER2 antibody drug conjugates, and 71% in cohort F, which is the treatment-naive cohort. Duration of response across the 3 cohorts was 9.2, 8.5, and 11.0 months, respectively. 12-month duration of response percentages were 42 and 29%. Median progression-free survival was 8.3 months in cohort D and 5.5 months in cohort E, and amazingly, Josh, not reached in cohort F. That's progression-free survival for patients with very aggressive subtypes of non-small cell lung cancer. In cohort D, patients with baseline brain metastases had similar overall response rates to those without, which demonstrates a very important part of any disease that has a HER2 alteration, which is the risk of brain metastases. So, cevabertinib may be one to watch in this rare subset, and you never know, it might find its way to other tumor types as well, but it is an oral agent, which is always a bonus. It seems to have decent brain penetrance in that it can control brain metastases. It can control disease at similar rates for patients with brain metastases and those without. And if you are treatment naive, especially, you have a good chance of having a very good response in terms of progression-free survival. So, Josh, an early phase study, but an exciting one.
What do you think their control arm is going to be for the phase 3?
Well, that's a very good question. And I think, because I'm slightly cynical, they'll have it against standard of care chemotherapy. Trastuzumab deruxtecan at this point is Muhammad Ali, Mike Tyson, Floyd Mayweather. No one wants to get into the ring with it. I suspect they would be standard of care chemotherapy.
It is nice to have an oral option, that's for sure. But it might take flight, but we'll have to see. And I'm going to move on to the ALBATROS study.
He spent my entire presentation thinking that one up.
I literally did. And I'm like, I've got to read through everything Michael just said so eloquently. But lorlatinib, which I kind of took a step back with this. I'm like, lorlatinib used in ROS1, but this is what the trial was. So it's the efficacy of lorlatinib after failure of a first-line ROS1 TKI in patients with advanced ROS1 non-small cell lung cancer, which is the ALBATROS study. It was a single-arm phase 2 study. So the current ESMO guidelines say you either use crizotinib or entrectinib as the preferred first-line treatments. Lorlatinib is an ATP competitive macrocyclic TKI targeting ROS1. It's potent, it's highly selective, it's here, it's ready to party. Michael, you didn't laugh.
I laughed on the inside. It's down and ready to clown.
So it was a phase 2 study in those who had progressed on one TKI, plus or minus 1 line of chemotherapy, plus or minus immunotherapy before TKI. So you could get the standard of care, which is fine. Good performance status. You were then given lorlatinib until progression or until toxicity. There was a baseline brain MRI because a lot of these cancers go directly to the brain. And the primary endpoint was investigator-assessed overall response rate, or ORR, at 8 weeks, confirmed at 16 weeks, so it's pretty early. Secondary endpoint was blinded independent central review, again, 8 weeks and then 16 weeks. Duration of response, disease control rate, PFS, OS, brain mets, objective response rate, safety. I love lung trials, Michael. I find them really clear the way they do things. It's very nice.
They're really straightforward and clear for us slightly dense people, aren't they?
Yeah, they're very dense as my hair gets longer. So in the result, there was about 50 patients included in the trial, average age in their 60s, more female, actually, which is interesting, probably because it's a mutation. 57 had brain mets at baseline, and over half had not smoked. Median follow-up of this trial was 31 months. The median duration on treatment was 8.8 months. Investigator assessed confirmed ORR at the 8 weeks was 30%, and the disease control rate at 8 weeks was 84%. The blinded independent clinical review objective response rate at 8 weeks was also 34%, and duration of response was 20 months. Median PFS was 7.4 months, and median OS was 42.3 months. In 13 patients with measurable brain mets, the brain met ORR, or objective response rate, was over 90%, and disease control rate was 100%. I love the fact this just loves attacking brain cancer, which is great. Treatment-related adverse events was 45% of patients, and 30% had at least one dose reduction. So this phase 2 shows some pretty robust clinical activity in those who had received at least one line of ROS1 TKI, mostly crizotinib, which is interesting. Highlights the question, like, is there a phase 3 trial for this, Michael? I couldn't find one online.
I don't believe so. I think that based on these results, they'll be doing a phase 3 trial, or they'll be pushing lorlatinib into the first line for ROS1, because obviously this is second line.
This is it, right? Because I'm like, okay, this has got pretty poorly, very limited options, unless you go through standard treatment, right? There's crizotinib, which is an ancient drug. There's entrectinib, which my experience is pretty toxic when I've used it.
Yeah, and I think there are concerns, and I might be wrong, about entrectinib's CNS penetrance as well, or that might be crizotinib. I don't think either one of them are particularly CNS penetrant, which is obviously where lorlatinib eats.
Everything.
I also love that lorlatinib, much like TDXD, is just sort of diversifying its portfolio. And I am waiting for the study where they do it in mutation wild type, like pan wild type, just for fun. And it's probably going to have a hazard ratio 0.2 in that as well.
Yeah, and they'll be like, well, thank you.
Yes, it's now first line therapy for everyone. So moving on, now we do love studies that open up exciting new directions in oncology. One thing we also like
Is when you guys subscribe and give us 5 stars. Is that what you were going to say, Michael?
I wasn't, but I'm glad you jumped in because that is a fantastic interjection there, Josh. Probably your best.
Probably is, and probably the most smart thing I'm going to say this episode.
Most smart original thing you're going to say, I reckon. What I was going to say before Josh very cleverly interrupted. We like studies that confirm something that we always suspected but never, I guess, really specifically knew. And that's where the PAULIEN study comes in. This is a study of pembrolizumab plus chemotherapy versus pembrolizumab as first-line therapy for advanced non-small cell lung cancer with a PD-L1 tumor proportion score of greater than or equal to 50%. Now you might think, Josh, Michael, hasn't this already been answered? Isn't this sort of standard of care? And you would be right in most places, particularly for those patients who have other comorbidities that makes us a little bit leery of using chemotherapy. As far as I'm aware, there has been no phase 3 randomized study that's actually looked at this. There is the various keynote studies. The only one I remember is 189. I think 407 was the other one of chemotherapy.
And 24. Oh, no, 24 was just immunotherapy, wasn't it?
Well, this is what I'm saying, is that there have been separate studies of chemoimmunotherapy versus chemo and immunotherapy versus chemo, but no one has actually combined immunotherapy with chemoimmunotherapy, as far as I'm aware. So that's what made this study exciting. So it's a multi-center trial that randomized patients 1-to-1 to receive pembrolizumab every 3 to 6 weeks, or pembrolizumab plus platinum-based, pembrolizumab plus platinum-based chemotherapy with either pemetrexed or paclitaxel. My plosives are going into overdrive here. Pembro and pemetrexed were continued as maintenance therapy after the completion of the platinum component. Randomization was stratified by the usual stuff: age, performance status, T-stage histology, and the center in which the patient was enrolled. Co-primary endpoints were investigator-assessed objective response rate and disease control rate at week 6 per RECIST, which is interesting because the one drawback we often say of immunotherapy is that it does take a little while to kick in. Secondary endpoints included progression-free survival and overall survival, and safety. Overall response rate and disease control rate at week 12 were also collected. So, interestingly, even though the summary here states that enrollment was halted for futility, I think what they're actually looking at, or what their hypothesis was, that the addition of chemotherapy would improve outcomes for combination over immunotherapy. So the ultimate answer is that this was not the case. A total of 72 patients were included, of whom 42 received the chemo-IO combination and 30 received pembrolizumab. Small study, but interesting. The overall response rate at week 6 was comparable, 33 versus 23% respectively, and it was not statistically significantly different. The disease control rate at week 6, 69 compared to 63% respectively, and the overall response rate and disease control rate at week 12 were also comparable. After a median follow-up of 29 months, with 46 events for PFS and 31.1 months with 37 events for OS, so when they had enough events to actually make a call on this, both PFS and OS were comparable between the two arms. The PFS hazard ratio was 0.91 with a very wide confidence interval, and the overall survival hazard ratio was 0.89, again with an even wider confidence interval. So, unsurprisingly as well, grade 3 to 4 treatment-related adverse events were occurring more frequently in the combination arm, 54 compared with 35%, and no treatment-related deaths were observed. So, even though it's not what the authors of PAULIEN were perhaps hypothesizing, this suggests, or can add to the body of clinical experience, that if you do have a patient with a PD-L1 CPS of greater than 50% and the diagnosis of metastatic non-small cell lung cancer, immunotherapy by itself is a very reasonable option. And where I'm working at the moment, that's pretty much the standard, particularly if you're getting sort of to 80 or 90% of PD-L1 CPS. You're really running out of reasons to give combination chemo and immunotherapy.
In that cohort of patients, of course.
Of course, if someone has a PDL1 of 1, then it's less likely. Although I have seen a patient with a PDL1 of 2% who had immunotherapy alone due to comorbidities and is doing brilliantly. So it's not an absolute.
Yeah, but you can dream that it would be an absolute.
We are a pair of dreamers, aren't we?
You know what? We probably are. I dream a lot. So this is the DREAMer study, and it's the primary result of durvalumab with chemotherapy as first-line treatment in advanced pleural mesothelioma. It was a phase 3 trial. It's a phase 3 randomized trial, which makes more sense based on all the reading I did. But the phase 2 DREAM trial showed promising activity of combining durvalumab and pemetrexed with the classic cisplatin or carboplatin for pleural mesothelioma. DREAMer with a 3 rather than an E evaluated chemotherapy plus durvalumab as a first-line systemic therapy for advanced pleural mesothelioma, compared initially with chemotherapy and later nivolumab and ipilimumab, following the results of Checkmate 743. You had to be an adult, you had to have measurable unresectable disease, a good performance status, no prior systemic therapy, and you were randomized 2-to-1 to the intervention arm versus the control arm. You were stratified according to age, histology, etc. Primary endpoint was OS, secondary endpoint was PFS, and ORR was another secondary endpoint and adverse events. There were 214 patients recruited, majority from Australia, which I thought was pretty great, and about 173 went directly to the chemo durvalumab and about 60 to the chemo. The median follow-up was 33 months, and the overall survival was 21 months for the intervention arm versus 18 months for the control arm, with a hazard ratio of 0.99, crossing the confidence interval. The progression-free survival was 8 months versus 7 months with a hazard ratio of 0.72, touching the confidence interval but not statistically significant. The only thing that was interesting was an objective response rate of 57 versus 35%, Michael. The adverse events were higher with the immunotherapy. That was probably the only really interesting thing in the trial. But what is more interesting is they've said early closure precludes definite conclusions about the benefit of adding durvalumab to chemotherapy. There were some notes that this was done during COVID and they had poor recruitment. I guess the question is, was the closure due to poor recruitment? It was not statistically significant because they didn't have the power. They didn't actually say that. They've just said it was closed and they can't make definitive conclusions, but purely based on the numbers, it doesn't really give us a benefit.
No. And I think we did want to give mesothelioma a bit of a mention, but it is interesting, I will say, that adding immunotherapy to chemotherapy is so much less effective than obviously Ipi-Nivo. Although I will say as well that numerically, I believe, if you look at the Ipi-Nivo study, the control arm actually is outperforming what you would consider a historical control by about 4 months. So that's something else to take into account.
But anyway, it's still, I can't kind of go to my patient. This would be a good second option for you.
No, exactly. So a little bit disappointing. The dream may have been shattered, but you never know. It actually was a really good year for lung cancer and thoracic cancers in general at ESMO 2025. And this is just a sort of a smattering of some of our favorite stuff, some of the more interesting stuff. We did have to leave a lot out, but we do come to our winner for our favorite study in the lung cancer space at ESMO 2025. And it seems the ESMO committee agreed because this is another presidential session. This is the OptiTrop Lung 04 study of sacituzumab, not govitecan, but tiramotecan, or SAC-TMT. And this is a study in a great area of need, as far as I'm aware, in patients with EGFR mutant non-small cell lung cancer who have progressed on EGFR TKIs. So going right up against the amivantamabs of the world. But critically, unlike Mariposa, SAC-TMT is not combined with chemotherapy. So the background, SAC-TMT is an antibody drug conjugate that targets the trophoblast cell surface antigen 2, or TROP2, I should say, that has shown significant survival benefits in patients with EGFR mutant non-small cell lung cancer that have progressed after EGFR TKI therapy and platinum-based chemotherapy. So now they're moving it forward, putting it up against that platinum-based chemotherapy. It is important to note, of course, that this is not in combination with what would be the current standard of care, which is amivantamab plus chemotherapy, but you can't have everything, hey? SAC-TMT has a bifunctional linker, which maximizes delivery of a belotecan derivative topoisomerase 1 inhibitor payload. And TROP2 is highly expressed in EGFR mutant non-small cell lung cancer patients and is associated with resistance to those EGFR TKIs. So in previous episodes, we've spoken about MET as a potential EGFR resistance mechanism. TROP2 expression is thought to be another one. So this was a phase 3 trial that enrolled patients with EGFR mutant, locally advanced or metastatic non-squamous non-small cell lung cancer, obviously progressed after those EGFR TKIs, and patients were randomly assigned 1-to-1 to receive either SAC-TMT monotherapy or pemetrexed plus platinum-based chemotherapy. Other key eligibility criteria, they had to have a good ECOG performance status, the EGFR mutations had to be EGFR sensitive, and the progression had to be either after a third-gen TKI therapy in the first line or after a first or second-gen TKI, so that's your lotinibs, your gefitinibs, with a negative T790M mutation, which was previously the only way we could get access to osimertinib. Patients were stratified as to whether they had prior EGFR TKI therapy, third-gen versus first or second-gen, or effectively no third-gen, and whether they had brain metastases. 376 patients underwent randomization, with 188 assigned to each group. And after a median follow-up of 18.9 months, let's get straight to the results here. The median PFS was 8.3 months in the SAC-TMT group and 4.3 months in the chemotherapy group, with a hazard ratio for disease progression or death of 0.49. The overall survival was likewise improved, with a hazard ratio of 0.60, and both of these were obviously statistically significant. 18-month overall survival was 65.8% compared to 48%. And the most common treatment-related adverse events were mainly hematological. SAC-TMT did have high rates of grade 3 neutropenia and grade 3 stomatitis. Other little tidbits, the PFS benefit, coming back to that, was observed across all subgroups, one of those really nice forest plots. The only subgroup that crossed the line of equivalence was those with brain mets, so I guess you could raise some questions about CNS penetrance of SAC-TMT. It's obviously a very complex molecule, so how that penetrates the blood-brain barrier should be further investigated. More patients in the chemotherapy arm had subsequent therapy, but this was largely driven by the fact that 19% compared to 1% in the SAC-TMT arm had subsequent antibody drug conjugates. The overall response rate, disease control rate, and the median duration of response were all favouring SAC-TMT. So in summary, you've got potentially a very tolerable, it seems, answer to the question, what do you do after patients have progressed on their osimertinib? It doesn't seem like there are later gen EGFR TKIs on the horizon. There is lazertinib kicking around, but I don't think that's ever really been studied as a monotherapy. So when you have patients who progress through osimertinib, what do? Well, you've got amivantamab plus chemo, and we've talked about the toxicity profile with that regimen, with its weekly infusions and its high rate of infusion reactions. Or you can have sacituzumab tirumatican, which is looking like a real good option. Very exciting.
It's nice to have decent results.
Yes, it is nice to have decent results in areas of need, isn't it?
Well, I think the thing is, like, I always struggle, and I've said this so many times on the podcast, like when we used to, all the old school oncologists just cycle through chemotherapies. That was their tradition. And sometimes you got lucky, you gave someone docetaxel or you gave someone paclitaxel and they just responded really well. But that was the minority, not a group of patients. And so it's good to see we have a second line therapy, which actually would work. They're going to probably try to push it to the first line. Who knows? Maybe not. Probably not with an EGFR, let's be honest. They're really rolling the dice with that one. That's an expensive trial for potentially a poor outcome, but it's great. Very happy.
Very, very good study.
Are we going to do neuroendocrine or do we want to save that for our next episode, Michael?
Why don't we leave our lovely listeners on tenterhooks and we can come back to neuroendocrine? The saga not only continues but expands. It's going to be ESMO 2026 by the time we're done at this rate.
Or 2027.
I'm sure he could string this out that long. But we hope you've enjoyed that episode. As we said, there was a lot to talk about in lung cancer, and this is the attenuated version. I think we cut about 4 or 5 studies from discussion just because it was going to be too long. But join us next time where the saga will continue with episode 395, where we will talk about neuroendocrine and melanoma. And don't worry, all you gastrointestinal, gastronomic fans and GU fans, upper GI, colorectal, and GU is definitely on the horizon. That will be episode 6943. But if you stick with us, you will get some good stuff, so we hope you do so. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.